Okay, let's talk about it one more time. So what happens to the first heart sound? First heart sound is normal because we do not have increased blood flow through pulmonary trunk. There is no definitive murmur in the first heart sound. And now second heart sound, because there is increased blood flow in the second heart sound, the P2 component, because second heart has two components, A2 and P2. So P2 will be accentuated because increased blood flow in the pulmonary trunk, and there is no variation in the second heart sound. What I want you people to do is congenital heart disease, it is all about physiology and anatomy. Okay. So what I want you to do today is you go back, you stay home, or you, whatever you do at home, you revise the cardiac physiology one more time, clinical examination, because if you do not have idea about CV physiology, you will have very difficult time understanding the congenital heart disease or any of the topic in the cardiovascular disease. Okay, so basic ko physiology, CVS ko physiology actually revise garne, murmur kasari form huncha, what is systolic murmur, what is diastolic murmur, first heart sound, second heart sound, third heart sound, fourth heart sound, those all lights actually revise garnu parcha. Okay, now about shunt murmur and flow murmur. Shunt murmur is basically a murmur that is through the defect. So AST there is defect between right atrium and left atrium. Now, since the pressure, right atrium and left atrium pressure is not much, so right atrium pressure 0 to 6 huna sakcha, left atrium pressure 8 to 10 millimeter of mercury huna sakcha. So pressure difference धेरै छैन. Pressure difference, when there is less pressure difference, you do not hear any shunt murmur in case of AST. Okay, AST the murmur is not through the defect. So what murmur are you hearing? You are basically hearing the flow murmur. So flow murmur is because of increased blood flow. So where was the increased blood flow? The increased blood flow was from the tricuspid valve ma increased blood flow cha, arko blood flow increase kaha cha? Pulmonary valve ma increased blood flow cha. Okay, so this is the flow murmur. This will cause the shunt murmur, and these increased blood flow will cause the flow murmur. Okay, always in the congenital heart defect, there is either a shunt murmur or a flow murmur. In case of AST, there is no shunt murmur, but there is flow murmur. Even if you do not remember the tricuspid, remember this one. So usually the murmur that you hear in the AST is because of increased blood flow to the pulmonary trunk, and the murmur you hear is ejection systolic murmur. Okay, so AST ma, the murmur that you hear in case of AST is ejection systolic murmur, which is a flow murmur because of increased blood flow through the pulmonary trunk. Clear about this? Clear?
Yes, ma'am.
Okay. Now, what investigation do we do? Again, we will be talking about three investigation: chest X-ray, ECG, and echocardiography. So what happens in chest X-ray? There is a little bit of cardiomegaly. Okay, the heart will be enlarged. Which part will be enlarged? Most commonly, right side of the heart will be enlarged. How do you know the right ventricle enlarged? This we will be talking in X-rays later on. Usually, right ventricular hypertrophy bhayo bhane your apex will be like this. Okay, so upturned apex huncha. Left ventricular hypertrophy bhayo bhane apex tala jancha. Apex yesto huncha. Okay, so this is usually there is cardiac enlarge, and cardiac enlargement is usually due to right heart enlarge. Okay, and there may be prominent pulmonary segment because of pulmonary artery hypertension. ECG ma pani ke huncha? Right side of the heart will be more prominent. So you have right axis deviation. Right axis deviation usually 1/3 limb ma huncha. This I won't go in detail, because if you have to remember, just remember the right axis deviation. Then again, we'll have to talk in detail about ECG. So right axis deviation ra V1 limb ma So you have RSR pattern. Okay, so this RSR pattern is seen in case of right axis deviation. So ECG ko detail we'll be talking in medicine class ma, and hamro ECG ko detail hamro final year ko classes ma huncha. So if you have to remember in ECG, there will be features of right heart, right ventricular hypertrophy ko features huncha. Okay, so echo ma ke thaha huncha? We will know about the position of the defect. Okay, here is the defect. So there is a defect between the right atrium and left atrium. So this ECG ko echocardiographic ko feri position will be different, like anatomical position banda different huncha. So echocardiography we basically do to find out the position of the defect. If you have to remember, chest X-ray ma ke huncha, there is a cardiomegaly, right side of the heart, right ventricular hypertrophy huncha. ECG ma pani there will be features of right ventricular hypertrophy, and in case of echo, we will find out the position, size, and flow. Okay, size of the AST थाहा पाउनलाई we need to do an echocardiography.
Ma'am, यो echoमा primum हो ma'am defect?
This echo, it is difficult to tell whether it's a primum, ostium primer, or a secondum. You need to find out different view. Okay, this is only one of the view of echo. Echo ma धेरैवटा view हुन्छ, तर यो primum ma जस्तै देखिरहेछ, तर we can't be sure in this view only. Okay, so you need lots of view in case of echocardiography to find out whether it is primum, secondum, sinus venosus, or coronary sinus. Okay, this is the simplest view मात्रै हो. AST छ भनेर मात्र diagnose हुन्छ. Okay, for kun ठाउँमा हो भन्नको लागि you need another view. है, बुझ्यौ?
Yes, ma'am, बुझ्यो.
Okay. So how do you manage AST? 20% of the case spontaneously close हुन्छ. If it is ostium secondum, most of the time it is closed spontaneously. Ostium primum will not close spontaneously. Okay, so spontaneous closure usually हामी AST भएको बच्चामा के गर्छौं? If the child doesn't have congestive cardiac failure, we ask them to come and do echo every 3 months. Most of the time, it is closed by itself. So you don't, the baby worry garnu pardaina, 3 महिनामा echo गर्न आउनु भनेर पठाउँछौं, है? So if the baby has like ostium primum ma छ भने, we are a little bit of worried. Okay, and if defect is large, 8 millimeter भन्दा ठूलो size छ भने, then we are worried. If defect less than 8 millimeters छ भने, you don't do. If the child goes in failure, we generally manage for failure. We'll talk about congestive heart failure later on. And usually what do? We make sure that the child doesn't have repeated respiratory tract infection. Okay, repeated respiratory tract infection usually bronchiolitis, severe form ma huna सक्छ. So supportive management matra गर्ने if the defect is small. Now if the defect is large, more than 8 millimeter size भयो भने, then this child will require surgery to close. Okay, now what happens is, if AST detected early closure भयो भने, the prognosis is very, very good. So spontaneous closure go छैन, school age सम्म पनि spontaneous closure भयो छैन भने problem के हुन्छ? You have extra amount of blood flowing in the lungs. Extra amount of blood flowing in the lungs भनेपछि there is persistent pulmonary hypertension. When there is persistent pulmonary hypertension, you have features of lung disease. Okay, so long time excessive pulmonary hypertension bio, long pulmonary hypertension bio, and some form of vascular changes in the lungs also. Okay, so it is better to diagnose atrial septal defect early in the life and close bhaira chaina bhane school janu bhanda agadi it should be closed. Okay, if it is not closed early, what will happen is later on the child may be present with chronic lung disease because of persistent pulmonary hypertension. Okay, and surgical repair ke garchhau, we do not go for open heart surgery nowadays. We go for non-invasive surgery like this. So what do? You send a catheter through the pulmonary vein bata jancha catheter, and then it goes into the heart, right atrium bata, and there you have a device like this, and you open up the device, and then you take out the catheter. Okay, this is the device closure of atrial septal defect. So these are the open heart surgery, non-invasive surgery. Okay, so this is the surgical procedure that we do to close atrial septal defect. Yahamsama ke questions, sir? Any question up to here? So management spontaneously closed for 20% of the time. Less than 8 millimeter kulai medical management, treat the congestive heart failure, treat the repeated chest infection, and more than 8 millimeter will require surgical closure. And surgical closure is device closure via the device which we send from the pulmonary vein, but it will go into the heart. You do not do open heart surgery. But you catheter pathaera right atrium pathauncha, right atrium there's a device like this which opens up, and this closes so this device will remain inside the child, and this is how AST is closed. This is the device that we use. Okay, and we should close the AST before as early as possible to prevent excessive blood flow in the lungs. which will lead to pulmonary hypertension and which will lead to chronic lung disease. So this is all about AST. Any questions? Any questions, Babu? कि सबै सुतिसक्यो?
Ma'am, के भन्छ यो क्लोजर हुनु भनेको त आफ्टर द डेलिभरी अफ द बेबी इन द के भन्छ न्यूनेटल पिरियडमा क्लोजर हुने होला हैन म्याम?
Neonatal period मा त्यति गर्दैन बाबु. Neonatal period is first 28 days of life.
Spontaneous closure भनेको म्याम नेचुरल क्लोजर जुन हुन्छ नि सिस्टेमिक
natural closure पनि 28 days मा हुँदैन. कसैको 3 महिनामा हुन्छ, कसैको 6 महिनामा हुन्छ, कसैको 2 वर्षमा हुन्छ. So if echocardiography, serial echocardiography गर्नुपर्छ, सानो भइराछ भने you don't do anything. But it is persistently high, pulmonary hypertension को features around थाले भने early closure गर्छ. प्राय अपरेशन्सहरु कहिले गर्छ बेबी को weight 10 kg भइसकेपछि 6 months भइसकेपछि and we know that the baby is able to tolerate anesthesia. Okay, even if it's a open heart surgery नभए पनि the baby लाई without anesthesia गर्दैन. So anesthesia tolerate गर्नु पर्यो, weight gain राम्रो गर्नु पर्यो हैन, त्यसपछि मात्र अपरेसन गर्छ. 7-8 वर्षसम्म नकुर्ने. If the AST is very big, you do not wait for 7 to 8 years to close the AST. Usually, if you have to do, you do it in the 2 years time. Okay? Okay. Any questions? Oh, if there are no more questions, next class we will be talking about VST, PTA, and coarctation of aorta, and especially cyanotic congenital heart disease. So basic idea yo tha paपछि त्यसरी नै जान्छ rest of the disease as well. What you do is next class you read up the cardiovascular physiology. Okay?
Okay, ma'am.
Okay, so I'm going to end the class now. Next class is VST, PDA, and coarctation. Read up, okay, before you come to the class.